Okay, well, thank you so much for joining us, and welcome to the CaTS webinar for March. Very lucky today to have with us Dr. Ron Horswell and San Xu, both from the Biomedical Informatics key component of the Pennington Center. I'm David Alexander from the Cyber Infrastructure Enhancement, KCA. And today, Dr. Horswell will be presenting on investigator access to large existing databases. And I'm going to hand the microphone over to him. If you have any questions today during the presentation, please leave them in our chat section, and we'll get to those at the end of the presentation. So without further ado, I'm going to hand the clicker over to Ron.
And the microphone is picking me up. Is that? Oh, I see.
Yes.
So, all right. Hopefully everybody can hear me. Thanks everyone for joining us. I'm Ron Horswell. I am here at Pennington, and San and I are both part of the Biomedical Informatics Core of CaTS. I'm also part of the Elbrin Bioinformatics Core. Before I get into the presentation, a little acknowledgments are, these are the members of our CaTS Biomedical Informatics Core. Lucio Miele is our director, core director. He's in New Orleans. Chindo, Dan Ford at Oxnard. Chris Taylor and Antonio down in New Orleans as well. San Chu here with me. She's in red there because a lot of this data access passes through her, and she's involved with it heavily. Connie Merla is red cap person here at Pennington. You've probably heard her present before, I think. And then me. Both Chris and I are, as the asterisks say, part of the Elbrin Bioinformatics Core as well. Chris is actually the core director for that core. And also we work very closely with, I didn't list all the LBRN people because that's a long list, and we also work very closely with ReachNet as far as data acquisition, which I'll come back and explain more about ReachNet in a little bit if you're not familiar with them. What I wanted to talk about today is, first of all, what databases are we talking about with external databases? Why would you want to access them? What are the main activities involved in accessing such databases, which is actually the main part of the presentation. How we can help you with data access, which basically means how we can help you with those activities. And what's your part? What do we need from you in order to be able to help you? And then some concluding comments about our overall vision and that the BMI Core has. What existing databases are we talking about? Well, it's quite a collection. Electronic medical records. And I'm not sure I have my most recent version of this because there's supposed to be a second one that says ReachNet data, because ReachNet is the PCORI-funded clinical data research network here in Louisiana, and they acquire and arrange medical record data from several provider systems in Louisiana, and we draw most of our EMR data through them. So point number one, it isn't necessarily true that all of it would come through ReachNet, but de facto most of it does. Databases such as adjuncts to EMRs that say radiology reports and images, pathology reports, health insurance data, we're accessing that now from certain, at least collaborating insurers. Louisiana tumor registry data is a big part of our data repertoire here. We have experience accessing EMS data, emergency medicine data, especially in East Baton Rouge Parish. Louisiana death registry data, also that's from LDH, Louisiana Department of Health. We're working on data to go with biorepositories that will improve the information that is available connected with samples. And we're also working on marrying data, EMR data type in particular, with existing genetic databases. Those last two are sort of in the future, but hopefully not far in the future. Why would you want to access such databases? Well, the preliminary data to support funding applications. Preliminary data covers a lot of ground. These are generic reasons, and they're more than these four. Support planning for prospective projects. We'll say a little more about that later. Sample design for subsequent projects. That's very similar to that. But overall, basically, the logical project in whatever your research stream is, your topic's next stream. I thought I'd give a couple of examples just to illustrate that, because those are general statements. These are past examples. We did a number of years ago a heart failure study, and with regard to supporting support for prospective trials, we used EMR data from the LSU Healthcare Services Division, which is a state hospital system, in a number of ways for this project. One was to design the project, the sample size and the site selection, where are the patients that you might recruit. Another one was to basically select subjects for a feasibility test, because this was a home monitoring study. Finally, we used the data also to support subject selection during the trial. We would identify from the scheduling systems potentially eligible patients who had to then be essentially referred into the trial from clinicians. And finally, we used the data for data analysis. And you can see some of the things. This is perhaps the main results slide. Up at the front end in planning it, we recruited the subjects and randomized them, but then we followed them for a year after that with these EMR data sources to get the outcomes. This is the reduction, relative risk reduction in inpatient and ED visits and so on. So the trial was successful. Another example, a more recent one, with the East Baton Rouge Parish EMS data, and in some ways a little more complicated. We needed, this was a project where we classified emergency department visits into various categories, depending on what was really the underlying, shall we say, cause or factor involved in them. We used the data to design the project. We also had to create this classification scheme, and we had to work iteratively with the clinicians in the EMS service to do that, so we used the data for that. We had to generate an internal linkage of the subjects. We had to create a linkage algorithm for this, because this is emergency data, and the data are not always that great as far as the identifiers. They don't stop when you're bleeding to ask you for your Social Security number, so or your insurance number necessarily. So we had to figure out how we would link the same subjects across multiple events, because that was an important part of our project, and then the final analysis. And there we saw things. One of our categories was potentially preventable ED visits, which were flat, and then, like some of the other categories, began to rise dramatically in the latter part of our data span. There's another, this keeps going. Now we're actually a continuation, a second project here. We're factoring in Louisiana Medicaid data for the parish here, East Baton Rouge Parish, and we're going to link those two data sources and do a validation exercise and essentially try to extend our EMR ED classification to be able to handle broader types of data. These are just to illustrate some of the possibilities, certainly not to say this is the scope of what can be done with this. One we've got going on now that we're in the process of acquiring the data for concerns the effects of cancer screening. This is a retrospective data analysis project. Our EMR data is coming from several providers, but through ReachNet, through their common data model. We'll have Medicaid data from Louisiana. Blue Cross Blue Shield of Louisiana is collaborating with us. We'll be acquiring data from them, and also from the Louisiana Tumor Registry, because we need their staging information in order to do this project. What we're going to do is we have to link those data sources, and so we're going to use what we call a GPID-based linking system. This is from ReachNet. It's actually from a group that spun off from Northwestern University in Chicago, but ReachNet is the one that's introduced it to Louisiana. And that will be our mechanism for linking these, because we need to know people who in the Medicaid database is also represented in the EMRs and so on. And then we use that, of course, to design the project, this EMR data. But we had to do a lot of methods development, and then we'll do the analysis once we get the data linked. We have a number of other examples. These are all underway right now in various stages: obesity and breast cancer, teenage pregnancy and contraceptive use. And you see over here the data sources. Basically, the ReachNet data means it's EMR data that we obtained from ReachNet. Racial differences in Parkinson's disease, effective influenza immunization, congenital heart disease in Louisiana, which is a linkage between ReachNet and LDH data. Diabetes measurement project, ReachNet data, racial differences in colorectal cancer using Oxner data. And what I'm going to talk about a little bit more here, obesity and cancer risk quantification. Frank Greenway's project here at Pennington. This is a multi-state project, And basically what we're going to do here is acquire data from Louisiana. We have to link it. It's the Louisiana providers again, which the data will come from ReachNet. The tumor registry, once again, the Louisiana death registry, because we do need to know when people died. And linked again here with probably with the GPID once again. But a similar exercise will occur with collaborators in other states, Alabama and Mississippi in particular. We'll move those data into a central analysis space where we can support analyses without moving the data out. Different people in different states actually participating in the analysis into a central site. So that takes us to the second point here, which are what are the main activities involved with accessing such databases. One way to look at it, and not the only way, is that it has these basic concepts. You have a topical area as an investigator, whatever your research area is. There's a project concept you have in mind. You're going to, of course, have to have a project protocol. The red arrows mean there's no data moving yet. But then if that protocol calls for data from one of these existing type of databases, you need to extract it. And then you've got to do some data preparation stuff, and then finally analyze your data. So what differentiates this type of project from some of the others? That's the main thing I want to go through here. First of all, once you have a project concept, you basically need preliminary support agreements, and not necessarily formal agreements, meaning that the data owning organizations, which is how we refer to these people that own these databases, you want to know that they're willing to support your project before you get too deep into that, because if they aren't willing to support it, why go on? You're going to have to do something else. You also, of course, the part we all know about is that once you've got a protocol, you need IRB approvals. In this case, for this type of project, you generally also need data use agreements between you or your organization and these organizations that own the data. I have a little thing here. Yes, I'll continue. Whoop. That's all right. We don't need it. Don't worry about it, David.
Sure. Okay.
Yeah. Just extraneous, probably. I think it was going to be an illustration of the data use agreement. The data use agreements basically, and the IRB as well, often refer to certain things that you need down in the data preparation. For example, if you've got more than one source over here, you probably are going to need some sort of linking methodology. You may not, but you might well need it. You also, in the data preparation, somewhere in the data preparation, there are various privacy protection features that have to be applied, because these data sources are very sensitive, and the data owning organizations will be very sensitive to that. And then there are certain ontology features. I'll come back to what I mean by that a little bit later at that phase. And then finally, it's going to go to some analysis location. Wherever this is going to be analyzed, the project team will have access to it. And that location has to have certain desirable privacy and security features. Now, our view here, and we're kind of maybe overly concerned. I don't say overly concerned. We're very concerned about the privacy and the security features. We like to see the basic ideas of what the specifications for these things embedded in the data use agreements and the IRB approved protocols. I'll come back to that in a little bit. But let's go back into a little more detail. With regard to these preliminary support agreements, which means you want somebody's data here, like LDH's or the EMR data in ReachNet. How are you going to go about, and you got a project in mind, how do you know that they would even collaborate with you? Well, one of the things is that in the initial concept, you probably, for this type of project, you probably need something more like the initial protocol version. And that's the basis for acquiring these support agreements. The good news is that many of these data owning organizations, especially the ones we're working with now, have defined ways by which investigators can get this initial approval. And they'll tell you whether they are willing to support your project. It may not be binding, but you can pretty much count on it. For example, Blue Cross Blue Shield, Louisiana, if you want their data, they can tell you how to go about how to go about talking with them to see if they're willing to help you. This is, you don't have to get the whole thing all the way through and then they throw cold water on it. It's way up front. Same with the Louisiana Tumor Registry, same with LDH, the Louisiana Department of Health, and especially the same with ReachNet, where they have a very nice formal mechanism for eliciting initial agreement to support a project from the organizations that contribute to their clinical data warehouse. Then these agreements are non-binding. I mean, you've got an initial protocol. If all of a sudden there in your final protocol you say you're going to go out and shoot people, then they might back out on you. But basically, if you continue through this, these people they're telling you up front, yeah, we will agree to support that, and they rationalize you continue to move forward. So you want to do that up front when you envision this happening. You don't want to wait till the end. Regarding IRB approvals, then, once you do that, you can finish your protocol. Regarding IRB approvals, there are some idiosyncratic considerations for projects like these that don't arise in some other types of projects that are entirely prospective. One thing that arises almost always, does arise in other projects too, but many of these projects of the type we're talking about here involve in one way or another more than one IRB. In fact, of all the projects I listed and went through up there, only one of them was a single IRB project, and that was the heart failure one, which was done years ago. All of our, shall we say, more recent projects, they all have multiple IRBs involved. In general, the IRB at each investigator's organization will be involved. This is pretty standard stuff. If you've got an investigator, co-investigator at Ochsner, then the Ochsner IRB is involved. If they're at Tulane, Tulane's involved, so on. A DOO means a data owning organization. That's the people that own these databases over here. A DOO may or may not require approval by its IRB. And this is important to know. If you're getting data through ReachNet, EMR data, and Ochsner, Tulane, UMC in New Orleans, they're among the big contributors into the ReachNet data warehouse. ReachNet collaborating DOOs only require IRB approval if the DOO has an investigator involved with the project. Now, that sounds like you might be able to skip them in many cases, but in fact, when ReachNet agrees to support a project, they also ask these collaborating organizations if they would like to have an investigator on your project, and they usually do. And so that means that those IRBs will be involved because of the investigator. But if they don't have an investigator, then these data owning organizations generally don't require that you really go through their IRB simply because you're using their data. On the other hand, LDH, which has its own IRB, does require that you go through their IRB for any project that uses their data, irrespective of whether or not there's an LDH investigator on it. And in addition, the other IRB approvals must be obtained first. LDH, if your protocol needs to go through Tulane or LSU Health Sciences Center or Pennington, wherever you are, in order to be, if you have to go through that IRB, the LDH IRB will not review your protocol until you've gone through the academic type IRBs first. We increasingly are using IREX or Smart IRB to create reliance arrangements, and this is in general helpful. It's taken us a while to work the bugs out of this, but we're working with our regulatory core here in CaTS to get this done. And this basically means, I say up here that more than one IRB may be involved, but it isn't necessarily true that all those IRBs literally review the protocol in the usual sense. They can rely on the review from a lead IRB, and those arrangements are made through IREX or Smart IRB. This, we think, is going to be especially helpful for protocol amendments because you can do the amendments through the main IRB, and the reliance arrangements will probably still all be in place. It is important to recognize that not all IRBs participate in reliance arrangements. For example, I don't believe LDH's IRB does, but most of the academic ones do now. Now, if your IRB will actually review rather than rely, one thing that we advise people for this type of project, these are retrospective data projects, and some IRBs and some investigators want to call them exempt. We would rather have you seek expedited review by your IRB so that it's literally been reviewed, it's just reviewed fast, doesn't go to the full board. Why? First of all, it doesn't require a whole lot more time. Takes an IRB just about as much time to think it's exempt as it does to expedite it. Journals may ultimately balk at an exempt or non-human subjects status, if you get that. Plus, you've got to keep in mind that you're getting data from these data owning organizations, and they may not like the exempt status. They may want to have the thing literally reviewed. And also, and most importantly perhaps, if the project will involve multiple IRBs, you probably want it's helpful if the IRBs are consistent in their perspectives. And so if some of them call it exempt and others call it expedited, you could have a problem here. The exempt status just leaves, in our opinion, room for disagreement and can cause more trouble than it's worth. So we advise people to go for expedited for this kind of thing. And above all, avoid thinking like this, that, oh, my project can be done with only de-identified data, so it does not require IRB approval. Generally, that's not true. There are very few projects that can be done using data that truly are unambiguously legally de-identified. I'm not a lawyer. I have some scruples. I'm not a lawyer, but this seems to be what the nature of it. It is, when I say unambiguously here, because actually IRBs differ and people differ on how they interpret what is legally de-identified. And that's another problem. If your data are legally de-identified, you could skip the IRB approval, you could skip the data use agreement. But there are very few of these projects where that is unambiguously so. And unless project data are truly legally, unambiguously de-identified, a project using data from covered entities, which basically, that's a HIPAA term, I guess, and that includes providers, it includes insurers, and a bunch of other type of entities, pretty much the ones we've got involved here, there has to be some sort of legal document that governs various aspects of data usage. They can't just give you the data, even if they want to. Legally, they can't do that when the data cannot truly be considered de-identified. And for most projects, that legal document is a DUA, or data use agreement, sometimes called a DUCA, a data use and confidentiality agreement, I think. However, that's a legal requirement. Even in the absence of it, the data owning organization would probably want something similar, because they want to protect themselves from how you may want to, they want to clarify how you're going to use the data. These DUAs should address various things. What specific data will be required? You may need an appendix to list it. We often do that. The privacy protection features, who's going to get the data, who will have access to it, restrictions on the location, security requirements for the data storage location. In our DUAs, we get David to write that stuff. He's written it for us, our cyber infrastructure people. Authorized uses of the data, which should reference the project protocol. And basically you say that the data can only be used for the purposes approved by the IRB in the project protocol, and how the data will ultimately be destroyed or stored long term. Now, the DUA is a document from the data owning organization. Let me see what I got next here. Oops, wrong thing. Should have stayed there. The DUA is a document from the data owning organization, but we often write the content for them. And they may put it in their form. So there's a lot of stuff here, but we pretty much have, we typically, when we're involved in one of these projects, we typically write this content and provide it to the organization that puts it in their particular form. Let's move down here to more detail on the linkage methodology. If you have a project that involves linking data across multiple data sources, two different organizations, an EMR, an insurer, or that sort of thing, there are a lot of ways to link data. I won't get into all the details, but as a practical matter, we can readily use either a GPID linkage, which is the one that ReachNet has been advocating and supports, or our own linkage methodology, meaning our BMI Core linkage methodology. They both have relative advantages and disadvantages, which I'm going to review here in a second, because this is kind of important to know. But technically, linking data, this is my judgment, is much less of a problem than most people think. People tend to think, oh, that's a big problem. How do we link it? Do this, do that. Really, it isn't much of a problem technically, but it does require some careful planning so you can support whatever methodology you choose. This is the GPID-based linking. This is the illustration of how it works. This is the one that ReachNet advocates. So if there are two, oops, this is supposed to say source data source number 2 here. So you got two different sources, say, of data. It could be more than two. What happens is there have been GPID-derived IDs. GPID stands for Global Patient Identifier. And so it's a methodology, and based on that methodology, there have been IDs, artificial IDs, assigned to every subject in this database, and the same with this one. And those artificial IDs are created by an algorithm, very good algorithm, from standard subject identifiers like social security number, age, birth date, gender, and so on. I'm skipping over a lot of the details, but essentially when these are exported, the GPID, when you get data for your project from your two data sources, the GPID IDs could be attached to them, and those GPID IDs or derived IDs are the basis for linking the data between these two sources at the subject level. Fundamentally, the same subject will have the same ID. It's not quite that simple because there's some confidentiality issues. But this provides the basis for linking. The advantages are that the GPID-derived IDs are already created. That is, these things aren't created just for your project. They're sitting out here in this database. They've already been created. So when it comes to your project, there's no de novo creation for an individual project. And also, it's just sitting there. So it's just like another data element that you can use to link. Very easy. There's also no subject identifiers are moved. Nobody's moving these original identifiers to you, and you don't want them. Somebody offers those to you, don't take them. The disadvantages, the GPID IDs must be updated. This is probably the biggest disadvantage. Occasionally you've got to update them because all these source databases are having new people added to them, and those people have to have GPID IDs derived. It also requires the existence of certain standard original identifiers in the source databases. That's usually not a problem, but some of the funkier databases, like the EMS one, they either don't have them or they're often missing, and then this doesn't work very well. All the source databases must be GPID enabled. So what that means is that all the sources that you're going to link have to be participating in this GPID scheme. Pretty much all the ones we've talked about are now. But you could have a very standard source and a provider system that you want to link to that's not participating in this, and so that could make it difficult. By contrast, we have this non-GPID method that's our own creation, where we basically, this gets pretty complicated, but we create a set of masked identifiers from the original subject identifiers, and then in one way or another, those things are extracted with the data, and the data are linked algorithmically using the masked identifiers. In a nutshell. Now, this has some advantages. One is it doesn't require a common set of identifiers, and you also can incorporate other types of data to improve the linking. The identifiers don't have to be just the usual suspects. You can use diagnosis codes and so on if you need to. However, it has some major disadvantages. One is this has to be done for every project, de novo. And also the more multi-organizational linking increases the complexity if you've got to link across more than two. And maybe most importantly, it's more difficult to explain to data owning organizations and to IRBs than is, say, the GPID method. So the bottom line, we can almost always link the data across organizations, but we prefer to use the GPID-enabled source databases whenever we can because it's just a smoother operation. Anyway, that's a little ditty on the diversion on the linking methodology. What's most important, we think, is that the linking should be accompanied by estimation of the linkage error levels. So there are two types of errors. You can link two cases. You can link parent subjects that turn out to be not the same person, and you can fail to link data belonging to an individual. Kind of a false positive, false negative, although probability theory-wise, that's not quite the right terms. But that's essentially it. And but the key thing is that the error rates depend on the quality of the data. So there's no way to say that the GPID gives you this error rate, these types of error rates, and that applies to every project. That's just not the case because the project differ. Even when you're linking the same two data sets, if the project differs, the error rates can differ. There should be a way, we would like to have a way to estimate the linkage error rates in a project-specific way. And the error rates are also differentially important. For some projects, it doesn't matter too much if you fail to link some people, but it can be very problematic if you create false linkages. In other projects, the failing to link can be really problematic. So we basically have developed a method methodology to estimate the project linking error rates. And one of our current projects that I went over there about the cancer screening actually includes another part, which is to pilot test this methodology for estimating error rates. Moving down to the privacy protection features, we suggest a number of things, and we try to typically apply them when we can. First of all, using random identifiers rather than encrypted identifiers. That's a technical thing. Just means how you generate. You're not going to get data with the original identifiers on it, except in very unusual circumstances, and you don't want that unless you absolutely have to have it, because it greatly increases your potential liability. We advocate use of random identifiers rather than identifiers generated by an algorithm. We also often randomly offset dates if the project allows. That means we assign every unique individual on a source database a certain random number of days, usually between plus and minus an integer, plus and minus, say, 60, omitting 0, and we add that number to that number of days to all the person's dates. So the spacing for any person is correct between dates, but the dates are all wrong. Some projects don't allow that, or you have to use some variant of that if you really need to know the exact dates, or a slight variant if you need to know the day of the week, which does happen. When people need addresses, if possible, if it could be allowed, if the project integrity of the project won't suffer, we offset geocoded addresses. We geocode the addresses, and then we randomly offset them, so we've got people living like a mile away from where they really do live in some arbitrary direction. And that works for most situations that need addresses at all or need locations at all. Now, important thing to keep in mind, despite what some people may think, these practices do not create de-identified data. This offsetting of the dates is probably technically insufficient to be de-identified. We never claim it is. So we don't claim that it allows you to skip any of these data use agreements or IRB approvals. Now going down here to ontology, and I've also added another thing, data cleaning, which is a consideration. Data cleaning means you transform in a standard way certain complex data to still complex data, but standard fields. I won't go through the details. We, for example, clean labs to certain standard fields, standard data elements, so that the labs could come in different formats, but we clean them to a standard element. We do the same thing with prescription data from EMRs. We clean them to certain standards elements. You see a few here, like how many refills, how many pills, what the daily dose is, and so on. How many days the prescription will last. By contrast, we use the term ontology to refer to mapping or translating data elements into clinical or research concepts, as opposed to just cleaning up the data. Here are a few examples. One of the standard ways to identify prescriptions, medications and prescriptions, is through RX CUIs, which I forgot what the CUI stands for, but some kind of code in the National Library of Medicine RX norm system. There are about 360,000 different CUIs. Here's a grouping we've done for one of our investigators here, where we mapped 47 of those to alpha glucose, whatever those are, inhibitors, either alone or in combination, could have been a combination drug, and so on. I highlighted in red here where we had 1,878 different codes mapped to beta blockers, any beta blocker alone or in combination, except the ones that are used for ophthalmological purposes only. And there are some of those. So anyway, you see these kind of mappings there. I highlighted this one in red. I'll come back to why in a second. Some other examples from current projects. We have a project mentioned earlier about teenage pregnancy and contraceptive use. Pregnancy codes, there are 31 CPT codes which are procedures that indicate pregnancy, not childbirth, but pregnancy. There are 943 ICD-10 codes, 487 ICD-9 codes, and those are just the ones that were used on the databases. These data came from LDH, from Medicaid data. Those are just the ones that were used. There are actually about 2 or 3 times this number of ICD-10 codes and ICD-9 codes that actually could mean pregnancy. They just weren't used. Childbirth or recent childbirth, such as postpartum events, among the used codes, there were 24 CPT codes, 303 ICD-10, 488 ICD-9 codes. So we've mapped those into those, pregnancy codes. It's actually considerably more complicated. And we preserve those ontology features because this is an unpleasant task. This is perhaps the most difficult part of the whole Data Acquisition Act, is to do this ontology mapping. So conceptually, we would have like pregnancy codes, a flag for those, and we mapped, 400 and some whatever ICD-9 diagnosis codes and the ICD-10. But we also then transfer those when we can by using crosswalks from the National Library of Medicine into other coding systems like the OMOP codes and so on. And so what we've done is we've created an ontology library with all kinds of code flagging definitions, and that's available for investigators to use. Now, when it comes to creating these type of ontology features, one might ask, well, isn't that just part of the project analysis? Well, actually, yes, it is. And usually, most places that supply data or help people acquire data don't provide all of this, and we don't necessarily always provide it. It is part of the analysis, but there are 4 reasons why it might be done, or at least partially done, before the final project data are delivered to a project team. One is you may need part of this in the data use agreement. You may have to specifically say what codes you want. Most organizations are not just going to say, you're not going to say, okay, give me all your data. They're not going to do that. You have to put some delimiters on it. And so you may need to do some of this figuring out these features in order to be able to tell them what data you want. I'll come back to this in a second. You may need to define how the data will be extracted from the original data sources, and again, to limit the data extraction. A big reason is this is a lot of work to do this, and so we want to preserve when it's done so we can use it again, or maybe use it as a basis, a beginning point for a modification of it. And then finally, I won't go into this in detail, but there's a need to validate these flagging systems. This exercise, like, did we get all the pregnancy codes? Did we get all this type of drug codes? This validation exercise is actually part of this. This all adds up to something that if you do it, whenever anybody does this, it's good to preserve it because it's time consuming to do. It's the most time consuming part in many ways of all this. Plus there are longitudinal ontology concepts or algorithms that we also preserve. For example, a person might be on beta blocker, but the question is, was the person on a beta blocker as of some date, for example, January 1st, 2017? And if so, how long had the person been on it as of that date? So it's not just a matter of flagging, it's integrating that flagging into a longitudinal sequence. I've got some others here. Whether a person was in a medical home patient population, that's a tricky one, but that comes up a lot. Was person X a known diabetes patient as of some date? And one we had recently that's trickier than all of these, when did person X become pregnant? We have all these pregnancy codes, but none of those codes show up on the day somebody became pregnant. You have to impute that, and that's an algorithmic thing. So those, in a sense, are also part of the expanded ontology. So we got those types of features there, some of which get embedded in these data use agreements. And as I said, the security and privacy features also are, we like to have them embedded there. One thing about the ontology, although I wanted to mention, is that some of the ontology features are actually necessary to define how you have to develop some ontology just to define how you're going to get the source data. Because consider what happens. When you want data from a source, typically it's a 2-step process. You have some extraction inclusion criteria, which are, who do you want in your data set? Who's eligible for this project? And so you have an extraction criteria that basically create a finder file, and then you, as we say, bounce the finder file against the source data and get all the other data elements that are needed for the project. And both of these may need some ontology work. Just how do you define this? Who is it that you want here? So all those ontology features, you have to define quite a bit to get that going. See, we got some strange things there. Now, with regard to the analysis location, just continuing to move down through the considerations here, we advocate a single location for the project. We don't always get this. And we advocate static storage in a truly de-identified form. Even though the data are not legally de-identified, they often can be stored when you're not analyzing them in that form. And we advocate certain security specifications for the analysis space. As I said, David's cyber infrastructure group has basically defined what we advocate here. So if they're deficient, it's David's fault. Now, why use all of these things? In a nutshell, what we're trying to achieve by the privacy protection and also these security features is really straightforward. If somebody does get unauthorized access to this, we want them to be able to get nothing but completely useless data. In particular, they can't identify any subjects or even group together the data element or the data records that go with a particular subject, and we believe that's doable if you do it right. And more generally, we want to create a climate of trust with our data owning organizations by being more circumspect than they expect us to be, or that they even require us to be, or legally that we're required to be. Okay, how can we help you do all that stuff? In a nutshell here, quickly, we can help you identify and interface with these data owning organizations, the BMI Core, and working with other, in particular ReachNet and some of the other organizations. We can help you write the portions of your protocol that are relevant to all of this stuff. In fact, we would like to help you write the protocol, portions of the protocol. We usually do write the data specifications for data use agreements. Typically, investigators should not write their own data use agreements. These are legal documents. And although we write the data guts of these documents, the structure of the document really came from our regulatory core. But we can do that part for you, and actually we would prefer to do it for you if we're involved in your project. In some cases, we can do the actual data extraction. For projects that acquire ReachNet data, we have an MOU whereby we can operate behind ReachNet's firewall as an agent of ReachNet to do the data extraction. ReachNet actually forwards the data to you, but we do the extraction. So we can take care of a lot of that. The trickier part of this is this data preparation phase, which you can think of as in two parts. A part that would be done at the source data. It's extracted, you do some data preparation at the data owning organizations. That's typically where the arrangements for the linking methodology would be done, and some of the privacy protection features. And also then, once the data come to your location, or they often come to us and we would distribute it if we're involved in the project, that's where the cleaning and ontology features would be done. So we can help do this, and we can furnish the data owning organizations, and do furnish them at times, with the computer code to do some of these other things. And of course also the linkage if necessary. If they're using our method, if they're using the GPID method, it's already there. So this gets split up. I've had it together up to this point. And we can help you develop these, in addition to that, we can help you develop these cleaning and ontology features that you need for your data as well. Because among other things, we have a motive for doing that. We want to store those ontology features and reuse them. Now, what's our overall objective? One of the objectives is we want to minimize the support burden placed on the data owning organizations. And we accomplish that largely by generating the data specifications with minimal involvement. If you have to work through all of these things by talking with the data owning organization, talking with their IT people, you can wear out your welcome. Understandably, these people end up working for you or for researchers in general rather than for their organizations. So we want to minimize this. It also minimizes the errors that can be involved and the miscommunications with regarding what's needed there. So we want to get this down to where there's relatively little for those people to do to support your project. And then hopefully we can also furnish an analysis space. That's a little more up in the air as to whether we can do that for every project, where you can pipe in to analyze the data. What's your part in all this? If we can help you with acquiring these data, we need kind of two main things from you. We need some involvement in your protocol development, and because obviously these things have protocol implications, and we really advise people to avoid premature IRB submissions. We have this happen where projects get submitted to the IRB, get approved, but they're not feasible to do because the presumed data sources just aren't there, or the data, or investigators don't understand what data are and are not there. So that I know investigators are often advised to get things to the IRB quickly. That's not a very good idea for this. More specifically, we like to see, sort of expanding these two points, especially the first, we like to see protocols driven by clear research questions, not vague aims, and with solid analysis plans, and also to envision what the next project may be, because you got to sell this project in some sense to the data owning organizations. Now, the upside is what we don't need from you. We're not just saying give us your final protocol and we'll kick in and help you. We can help you before that. We don't want an existing IRB approval. We're not saying we can't help you until you get this. In fact, we would prefer to start helping you before you get this, as I mentioned. We don't want you to give us a list of required data elements necessarily, especially not the specific codes for diagnosis codes or so on. That's a tricky thing to develop. We would rather help you develop it. We don't want you to get us the DUA content. We don't want you don't have to worry about the linking methodology as far as developing it. And you don't really have to worry about the approval from the data owning organizations. If you got it, great. That prior approval, we can help you get that. A little bit of expansion here about what I meant by the research questions, how we like those. This is an example from Dr. Greenway's project here. The overall topic, obesity and risk of cancer. Fundamentally, the background for this project leads up to a conjecture. I use the term conjecture. Some people say working hypothesis. I'm a statistician. I don't like the term working hypothesis. I think it's confusing. It's really a conjecture. And the conjecture here is that this is about a certain staging system, obesity-related staging system, but it factors in other comorbidities as opposed to just BMI categories. The conjecture is that this more elaborate staging system will capture cancer risk better than staging based only on obesity. This is fairly significant, important conjecture, actually. That's what the conjecture here is. So this leads to some specific research questions, and this is all in the background. For example, I'll just go through a couple of them. Among obese adults, do these stages here exhibit a monotonic relationship to cancer-related risk? In other words, lower stage, lower risk, higher, next stage, higher risk, next stage, at least monotonic, if not strictly increasing. And if so, do the EOSS stages, this staging system, explain additional cancer risk beyond what is explained by the BMI categories? In other words, are they adding any explanatory power to the BMI categories? I won't go through the rest of them, but those are very specific questions. The aims then actually just essentially say, we want to answer this question, we want to answer this question. When you're working with these types of projects and trying to figure out your data needs, these specific questions, as opposed to just aims, is really what helps us figure out what data elements are needed. In this case, then, the methods you go on and it gets into hypothesis testing and all that. And the methodology is pretty elaborate, such that it even continues in an appendix. But it's hard to know what the data elements are in many cases without specific questions. Often the way aims are written, they're not sufficient. So we really like to see the questions. Main points, you want to try to avoid unnecessarily exploratory protocols that don't have questions, don't have hypothesis tests, that type of thing. Because how do you convince data owning? It's not really in most investigators' interest to have something that exploratory as far as what they're going to do with the results. And how do it's hard to convince data owning organizations to support that. And you may need more than just vague statements, hand waving about the statistical modeling or other methods, and you don't want to assume it'll be easy. These are often very difficult projects to analyze. These retrospective, if it's retrospective data, it can be quite difficult. And I'm saying all this because we don't want to go through all the hassle of getting data from data owning organizations and then find out we can't analyze it or that it won't work. So it does require a lot of upfront thought. Quick concluding comments about our vision. This is beyond what we've covered here. What we really envision, what we're trying to work toward as a BMI core, our informatics vision, is that we actually have federated data warehouses where we have we derive them from various data sources. They have a similar structure. They've got ontology features on them. They may be linkage enabled by already having the GPID on them, that sort of thing. And that makes it relatively easy once a project is approved to draw off the data, link it, plop it in some space where people can analyze it. This is sort of the vision that we have, as opposed to everything being one-off and every request having to go down and talk to people. Well, just what's in your EMR and how do we get it? We'd rather have it pre-prepared, so to speak, so we can draw it off more readily. What are our current challenges? Briefly, in pursuing that vision, first of all, a lot of overestimation of the technical difficulties. People think there's all kinds of technical stuff. Most of it's just organizational issues. IRB reliance arrangements, DUA creation, some of this has been clumsy. It's really smoothing out now. Increasing the number of collaborative provider systems. That's a big need that we have right now. And we're trying to work on that, and hopefully some projects that some of you may suggest will help us do that. Analysis bottleneck. These things are complicated to analyze, and basically now we have enough data coming in to where our bottleneck is actually not involved in anything acquiring the data, but just in analyzing it. Analysis spaces, how to really configure that, that's a current challenge. Some of the bigger immediate challenges, we think, are obtaining non-standard data not available in standard EMR supported forms. I mentioned some of it earlier, and prospective clinical sites. Regarding the non-standard data, we have a couple projects already defined. You see the investigators there. Atrial fibrillation and cancer. This one actually requires EKG reports, which is non-standard. They're not automatically embedded in EMRs. You got to go get a different source through. And machine reading and analysis of mammography images, we need radiology images and reports. Again, non-standard. These are some current challenges, acquiring those. And as far as the prospective sites, this goes back to that EMS project where we're doing this right now, but ultimately the whole point of this is to get some intervention design and testing and be able to really fluidly go from this background research into that testing. That's one of the biggest, probably the biggest challenge we have. To contact us, you could go to the CaTS website. This is actually the link that will take you right to a contact page on that website, and I won't go there right now, but you can fill out a question. We would just assume you emailed us. This is me, this is San, and with questions, or we can set up a phone conversation and all that good stuff. I should mention that we often invite investigators who have relevant project ideas to our weekly CaTS BMI Core meeting, which we hold via WebEx Tuesdays at 2:30, and we can arrange some other time if we need to. The advantage, so if you email us or go through the website and we talk to you, we might then say, why don't you join one of these meetings? The advantage of this is that we got other members of the core there. Lucio, our core lead, Dan Ford from Oxner usually joins these as well. And these, so you get other perspectives, and those other perspectives can be, valuable, not just talking to people beyond just San and myself about the essence of your idea, how to pursue it. So we like to do that. We have some future topics that we may do future seminars like this on, webinars. I just mentioned them here. One is analysis methods for retrospective observational data. There's some types of methods that are you may not be familiar with, that are worth knowing about, that often come into play with these types of, especially the retrospective data. How you would create these ontology flags, those hundreds of codes, and how do you validate them, or how can you work with us to do that? Exactly how we're planning to estimate these error rates for linkage methodologies, and a little more about how they work. In the future, hopefully, use of retrospective project results to support design of genetic or epigenetic projects. We think we're maybe moving towards being able to do, support that type of thing. And also use of retrospective project results to design prospective interventions. I think that's it.
Wow.
Thanks, David.
Thank you, Ron. That was great. You brought that in right in an hour, too. It was almost perfectly planned.
Yeah, I talk fast.
That was content rich. Okay, let's check to see if we have some questions in the chat room for Ron. See what we have. Okay, there's none waiting here. I had a question. When you were describing the, just from an algorithm perspective, you were describing extracting data and then preparing data, and and this offset that you use across records for obfuscating dates and geolocation. Do you care to store that constant when you're doing that process, or is this because you have the source data, it's on its way to prepare, you don't really care, you just want the algorithm to be consistent? Do you preserve that offset per record? Or? We
usually preserve it in one way or another, and we typically leave it behind at the source data.
Okay.
So it could be it could be undone in that sense.
Okay.
I don't know that we've ever undone one, but it could happen. And so essentially we leave behind a crosswalk between and oftentimes the original identifier isn't a real one either. Like in the ReachNet, they have what they call a patient ID, which isn't the original identifier either. There's another crosswalk that somebody else has, probably like Oxner or the source data, between the original the true ID, say a medical record number, and the patient ID. And so our crosswalk is between the patient ID and a random number that we've assigned. So, but yeah, we typically leave them behind. But we don't bring them to the investigator, otherwise we wouldn't be doing anything, right?
Right. So, here we go. Here's a question. So, is the email you listed your preferred point of contact for collaboration? So I think the question is about the
we would just soon use the email rather than the CaTS one. But we'll see the CaTS one either way, and don't feel like you got to go through if you send us an email or you go to the CaTS website, please don't feel like you got to have some big elaborate description of your project or your idea. We just soon get on the phone and talk to you about it. So maybe we can use the email just to arrange a good time when we can talk by phone. If that answers the question.
Great.
The email is probably better, either Son or myself.
Great. Good. Okay. And like always, I will, if Ron and Sam are okay with it, we'll get this content out on YouTube later today, so that if you missed or you joined us late, or you want to go back and see something that Ron covered, you'll be able to fast forward through the video. So we'll have that available later today. Thank you for those future topics, Ron. We'll definitely take you up on those if you'd like to come back and present on those. And then if you're watching this and you have an idea for something we haven't done yet in a webinar and you'd like to see it, go ahead and email info@lacats.org, and I'll have that in the YouTube description as well. And if no one has any other questions, then we'll close for March, and we will see you all in April. Thanks for joining, and thanks for presenting.
Thank you.
Thanks.
Great.
Thank you.